Okay. It's my absolute pleasure to welcome us to this occasion of the 20th anniversary of the Africa Health Development Care Health Trust. My name is Dr. Falolu Dahiru Danwata. I am the organizing committee chair. I have the support of my committee members and our executive committee. And it is my pleasure and privilege to welcome His Excellency, the High Commissioner of Nigeria to the UK, His Excellency Chief Sarafatunji Ishola. As you all know, honestly, all the people that are on this panel have a status which doesn't need accolades, but just for introduction to the attendees as well as everyone on the platform, I want to give some brief bio information about His Excellency. Chief Sarafatunji Ishola, his early education was in Abeokuta in Ogun State. He attended his college and university education in London and in the US. And he went back to Nigeria and obtained his master's degree in business administration in University of Ilorin. And his national outlook started when he did his NYSC in Katsina State. He served in the Federal College of Education in Katsina State. After his NYSC, he stayed in Katsina State and also served as a lecturer in the same Federal College of Education for about 3 years. And then thereafter, His Excellency went back to Ogun State and served as Chief Executive of the Broadcasting Corporation of the state. And then he swapped onto the private sector, where he became the executive chairman of Taste Nigeria Limited. His Excellency's political life include chairman of Abeokuta North Local Government, special assistant to the Honorable Minister of State for Finance in 1999 to 2003, and Secretary of Ogun State Government of 2003 to 2007. And His Excellency also served as Honorable Minister of Mines and Steel Development in Nigeria. Chief Ishola's vision is a model in good governance and best practice. His mission is constructive development and people's welfare. His ethos include service, trust, and integrity. And his passion is law and order, people's welfare, social infrastructure, and economic development. So, Your Excellency, we are very pleased to have you at this occasion to declare our 20th anniversary conference open. Thank you, sir.
Good morning, Chairman, Organizing Committee, members, and other delegates to this conference. It's a pleasure to be with you. I want to say the mission will continue to identify with AHDT because we share in your concerns. We also share in your objectives, and I assure you that the mission will continue to collaborate with you. So welcome you.
Thank you very much, sir. We are most grateful for your presence at this occasion. Obviously, as we go through the program, His Excellency will be with us. And during the course of the program, I'm sure if there are relevant other issues that we will need to refer to His Excellency, we'll do that. Now I want to introduce the Africa Health Development Healthcare Trust Chairman, Dr. Ibrahim Hassan Jallo. Dr. Ibrahim Hassan Jallo is a consultant medical microbiologist who initially served at Stephen Hill Hospital and went on to Stockholm Hospital, where he is currently consultant in infectious diseases. He is involved in microbial stewardship infection prevention team and served as a member of the microbial committee. He has held management positions in his hospital as clinical lead and head of department. And he also led the microbiology service development in a development of microbiology automation system in the hospital. He has presented a number of papers in both at local and international conferences and has published also. He's currently chair of the Northwest Infection Control team. He is an RCP pathology examiner. Dr. Ibrahim Hassan is a founding member of this charity, and he is currently the chairman of the charity. Dr. Ibrahim Hassan has other hobbies such as reading about personalities like Nelson Mandela, Malcolm X, and Muhammad Ali. Dr. Ibrahim Hassan is quite an inspiring leading member of this charity. So Dr. Ibrahim Hassan, go ahead and give your presentation for this 20th anniversary. You need to unmute yourself. Dr.
Thank you very much, Salah, for your kind introduction. I'm going to talk to you briefly about the history of AHDT, in which I will tell you briefly about how the association was formed and what activities we've done and how we've learned from some of the mistakes that we committed earlier as part of our learning experience. At the end, I'll also launch what we call our 20-year project book. The book contains all our activities that we've done over the last 20 years. I will say the first formal meeting in which AHDT was born happened on the 21st of January 2002, during which we decided to form this association. Before this time, what has happened is when we go on holiday to Nigeria, all of us visit our colleagues who are based in the hospital and clinics, and we just help them to do whatever they are doing. So we decided that if we pull our resources together and form an association, the impact will be much bigger. And this was what we did. So within the next 10 years, exactly on the 18th of July, we got registration from the UK-based Charity Commission, which granted us registration to start functioning fully as a charity. We went through a number of names to decide what is best for the name of the organization. We decided on AHDT, which is Africa Healthcare Development Trust, to underscore the point that our mission is eventually to cover health activities on the entire continent, obviously with the focus of activities starting in northern Nigeria. And our website address is www.ahdt.co.uk. Okay, I'll go through the next few slides talking about our operational adjustment. When we started, we were collecting consumables in different parts of our hospital, putting them together and shipping them to Nigeria. We soon realized that this is actually consuming a lot of our meager resources. So we moved into health campaign issues. One of the most successful ones we did very early on was around HIV, in which we partnered with colleagues on the ground. We provided them with the support, and also we participated actively. Some of the things that they used, including the process, were actually donated to them by AHDT. The next big step in our development is when we started doing hospital-based projects. And what that means is we have a group from here that go to Nigeria with and base ourselves for 1 week or 2 weeks in this hospital, and we help them run their services. What that means is we just basically increase the capacity of the hospital by providing additional manpower, both for medical nursing as well as some of the consumables. The 1 week project is what we call minor project, and the major project is when we go there for 2 weeks. Even our logos has changed over the years. When we started, the mission statement we had on our old logo is Healthcare for Africa. As we fine-tune our activities and develop into education and training, we improve the mission statement to focus on that. So the current mission statement is improving healthcare and supporting medical education. And this is our current logo that we are going to use for the future. I'll give you an example of some of the achievements that we have so far done. So far, we've treated more than 20,000 adults and children free of charge in northern Nigeria. We've also, this includes operation for surgical conditions like cataract, hernia, hydrocele, and also VVF, vesicovaginal fistula. This is a very, very big condition which is prevalent in northern Nigeria. It affects young women who have got trauma during their birth. What happens with these patients is that they begin to leak feces and urine, and effectively they smell all the time. So we also identify these people, bring them together, repair their VVF, and try to resuscitate them back into their local communities. We also run clinics to take care of chronic conditions like hypertension, diabetes, and so on. We are involved heavily in training as part of our hospital project. We train conventional midwives, but also traditional birth attendants in the internationally recognized newborn resuscitation program. What may not be clear to some of you is that more than up to 80% of childbirth in Nigeria happens outside the healthcare setting. So these traditional birth attendants are the people who manage those kind of complicated deliveries. This happens at homes, in rural villages, in towns, and also even in cities. We've also paid for upgrades facilities when we visit hospitals. One of the important things that we've done is to upgrade all the facilities, including the theaters that we use for our surgery. We've also run healthcare campaigns as well as providing services in IDP camps. There are a lot of internally displaced camps across Nigeria as a result of the Boko Haram insurgency, which has devastated the area for almost 2 decades now. So as part of our training for the traditional birth attendant, we provide them at the end of the training with safe birth kits, which they take to their localities to improve their practice. What we tend to do is to actually fine-tune their skills, improve particularly their hygiene, as well as some of their aseptic technique. And this is something that we've impacted on them. So our focus at the moment is manpower training, skill development, and capacity building for all healthcare workers. And this is an area that we intend to improve on as we get along. We also do a continuous monitoring of our activities, both formally as well as informally through the audit process. One of the formal audits we did was actually published in a peer-reviewed journal, Annals of African Medicine, in the year 2018, the January to March edition. The title of the paper is Evaluation of Cognitive Effect of Newborn Resuscitation Training on Healthcare Worker in Related State in Northern Nigeria. This, we can discuss a little bit more about the paper if you're interested during the question and answer sessions. We have so far completed and successfully implemented hostel-based projects in at least 6 to 7 states in northern Nigeria, including Jigawa, Kano, Gombe, Kaduna, Adamawa, and Niger states. We've also signed memorandum of understanding with institutions of higher learning. For example, ABU Teaching Hostel, Gombe Teaching Hostel, Aminu Kano Teaching Hostel, and some of the, for example, also IBB University in Lapai, Niger State to support their new medical school. We've also signed MOUs with other individual philanthropic organizations, including an orphanage center item, as well as the Gumel Foundation. We set up prices and bursaries in various universities to improve excellence. And also we've done a lot of exchange skills between medical and nursing colleagues, both from the UK to Nigeria and then vice versa. The centers that have benefited most, not exclusively, the hub is ABU Teachers in Nigeria, but also Stockport NHS and United Lincoln Hospitals, which are the centers that have participated actively in this exchange program. Some of the beneficiaries have also gone back and are occupying very high senior positions in Nigeria already. What are the new areas that we've done? Having consolidated our hostel-based project, we decided then to look at new areas. We identified mental health as an area that requires our attention. For example, as we go to do our project in Nigeria, we realize that there is actually a lot of drug abuse. And what is happening is this is affecting young mothers. And in Nigeria, still culturally, young mothers are responsible for the upbringing of children most of the time. So we are concerned that if there is drug abuse among young mothers, it is just the fabric of the society is on a very shaky ground. So what we did was in 2019, we launched a 10-year development program in which we intend to collaborate with key stakeholders, both governmental and non-governmental organizations, in order to chip away at this very, very difficult area. The second area we identified is actually research collaboration. One of the links that we're involved in at the moment is with the Neurosciences Department of the University of Manchester and in collaboration with ABU Zaria. The title of the collaboration research is Folate Handling in the Developing Brain and Prevention of Brain Abnormalities. This will lead to a conferment of PhD, and the idea is to give it a global foundation. Our link in the University of Manchester is Dr. Jalil Mian, who has attended a few of the AHDT meetings as well. The idea of this research is that folate supplement, there's a condition called hydrocephalus, in which children develop very big head as a result of the trauma that they got, usually during childbirth. The idea of this research is that folate supplement can be used to minimize the damage that is happening to the brain of these children, or even better, to improve and prevent it potentially by using folate supplement. So who are our key allies and partners? It is very, very difficult to mention everybody that has contributed to where we are today, but I must start by thanking all our ordinary membership, our ESCO, our trustees and patrons. Some of us from the beginning are here up to now. Others have moved on, but I want to extend my thanks to all of you who have been involved in the past or even still continue to do that. We also have partners locally as well as internationally. The local ones are mainly in ABU Teaching Hospital, which provide the hub of the workforce that we require on the ground to do our various projects in Nigeria. Internationally, we've got the International Health Partnership, which is a UK-based organization that provides us with heavily discounted consumables and equipment whenever we are going to Nigeria, including medications. I'm happy to say that we've been identified as a key partner by IHB during an award during the Queen's Award for Enterprise and Innovation, which happened on 21st of December 2011. I remember there was a big party where the good and the great attended in London. We sent 1 or 2 representatives, and I think Ibrahim Dodo, who is a founding member of AHDT, I think he and some other person represented us during this occasion. So I would like to congratulate all members for this award, definitely as a testimony for what we've done. Please permit me to mention Ms. Anna Craven. Anna Craven sadly has passed away this week, actually last Monday. Anna has been a founding member and also one of our founding patrons of the organization. Anna has been with us from the beginning. She's also been involved in collecting charitable money, which she donates to AHDT, but also she accompanied us to Gombe State when we went to do a major project in 2013. Our thoughts at the moment are those with our family. We cannot thank Anna enough. What are the challenging areas that we were able to find and somehow work around it? The ESCO definitely has been expanding, but the general membership drive has not been as successful as we want it to be. In particular, we are short of women membership and also non-medical membership. I put non-medical in big capital to emphasize the point that without the participation of non-medical members, this charity would not have achieved half of what it has achieved. And I'll give you just a couple of examples. A couple of the non-medical members, for example, Abdullah Sharif has been with us for more than 5 years now. Since he came, he's been the backbone of running the activities of our offices, providing all the support of the secretariat that is required, and without which it would have been impossible. The second person we co-opted recently is Ahmed Khalifa. Together with their participation, we've been able to facilitate this Zoom meeting. It is fair to say that without the participation of these two, it would have been impossible to have this current Zoom conference that we're having. So we thank them enough. There are also others who I would not have time to mention, but I thank them all for that. So whatever your background, please come forward and help us. Despite all these problems, our efforts remain that of sacrificial giving and of action rather than words. And we remain grateful for the core members who have helped us to do this. We're all doing this out of our part-time basis. We all have full-time jobs. So it has not been possible to get time to apply for big funding from organizations, whether in Nigeria or here. It's something that we want you to come forward and help us with. Another challenge we face is what I call the Nigerian factor. Over the past 20 years of going to Nigeria, we have learned so much, but we've also been challenged in all various forms and shapes that you can imagine. On one hand, we've met Nigerians who are on the ground, who work in Nigeria, who are impeccable. They have really been inspirational. And one classic example is one of our guest speakers. Lawan Umar has been there at the beginning, and he's still here with us, and he does participate in almost all the projects that we do on the ground, despite all his clinical as well as other management commitments. So we thank you and all the others. On the other hand, there are Nigerians who are not interested. What we also came to realize is that everybody assumes that any organization coming from abroad is an NGO, a non-governmental organization. This is because those NGOs in Nigeria who participate in healthcare associated work tend to come with a lot of funding. When they go, they appoint local people, they pay them fantastic wages, and they get them to do the work for them. So when we went, the expectation is that we are going to pay people to do this work. Unfortunately, we kept telling people we are an NGO. We are not an NGO, but we are a charity. Eventually, most of them left because they didn't believe us, but a few of them stuck behind and realized that, yes, actually, our modus of operandi is completely different. And none of us is paid to do this work. And thank God, a lot of them are coming also to give us their time free of charge, as we also do. How do we finance our project? We finance our project by member subscription, as well as charitable donation by philanthropists, and both in Nigeria and abroad. The logistics, when we go to Nigeria in terms of transportation, accommodation, and feeding is provided by the local communities. So what we do is we provide our expertise free of charge, and the entire work is done voluntarily. What is our mission? Our mission basically is to expand our work beyond northern Nigeria into other parts of Nigeria. For example, we've got invitation just at the end of 2019 to go to Abeokuta, which is in the southwest state of Ogun State. But for the COVID, we could have done the project in Ogun State in the year 2020. So this is on hold till after the pandemic. What we are trying to do, despite all the challenges, is we provide a refreshing departure from those who simply complain and criticize without offering solutions. And this is the way we see our activities. If you'd like to partner us for a project, simply email us or go to our website or go to the website and you find the information there. On the other hand, you can also contact our project lead and project coordinator, Dr. Abubakar Zubairu, who is a consultant pediatrician working in South Australia as myself. Abubakar Zubairu is what we call our AHDT Maradona. Over the past 15 to 20 years, Abubakar has developed the skills, the arts, and the science of learning to dribble through all the potential obstacles that could be put in our way to scupper our project. And what that means is Abubakar does the surveillance visits prior to going to Nigeria for a project. And once Abubakar gives us the thumbs up, it means that all the potential ruby traps and all the landmarks have been cleared, which means we go there and we have a very successful experience. So I would like to take this opportunity to thank Abubakar, our project coordinator and project lead, as well as members of his team, because without their work on the ground, at the background, it would have been impossible to have this successful project. So in conclusion, from the bottom of my heart, I would like to launch the AHDT book, which covers the 20 years of the activities that we've done. It is basically contains all the activities and projects, and I would like to thank you for your support. This book is something we want to share with you to show you how much an impact you have made by supporting us. You can download this e-copy freely from the AHDT website. And I'm also delighted that you've been able to join us for this, what I believe will be a successful celebration. It is an opportunity for all of us to analyze our strengths, our weaknesses, our opportunities, and the threats. I thank you very much. And please pardon me if I do not mention too many names as part of the contribution. So thank you very much. Welcome any questions, any comments. And if you'd like any more information, please go to our website. Thank you very much, Falalu. Thank you, everybody.
Thank you, Chairman, for your very succinct and informative presentation. to our audience. In our midst, we have our patron, His Royal Highness Etsunupe, Dr. Alhaji Yahaya Abubakar. I want to introduce His Royal Highness as he will be giving us his next keynote speech. His Royal Highness Etsunupe, Dr. Alhaji Yahaya Abubakar, started his education in Sokoto Government College. And then after that, he went to Commercial College, Kano. Following completion of his study in Commercial College, Kano, he joined the Nigerian Defense Academy and became an accomplished military officer. Prior to his retirement and becoming His Royal Highness, the last military posting he had was at the Defense Headquarters, Abuja, where he was Director of Foreign Operations. He retired as a Brigadier General in September 2003. He was then appointed the 13th Esunupe on the 11th of September 2003, following succession of his late uncle, Alhaji Umar Sanda Indayako. By virtue of his status, His Royal Highness is the chairman of the Niger State Council of Traditional Rulers. His Royal Highness is also the Chancellor of Obafemi Awolowo University in Ife and Ekpoma University in Benin. And we also have the privilege of having His Royal Highness as our patron. That is the patron of the Africa Health Development Care Health Trust. I hereby welcome you, sir, to this historic conference, and we will want to listen to your fatherly key speech for this 20th anniversary meeting. Thank you.
Good morning.
Good morning, sir.
Yes, we thank God the Almighty, Allah, giving us life and time to witness this very, very august occasion of 20th anniversary of Africa Health Trust Development Fund Trust, sorry, which we're celebrating today, and also wishing the founding fathers, there is a whole group of members, very, very eminent personalities, doctors, who actually formed this organization, and who, through their professional outings, they are rendering very, very tremendous service to humanity in terms of health services and healthcare, which my people in Bida Emirate actually enjoyed very, very well. I remember the time they came to Bida here, then there are so many, they're supposed to treat maybe few hundreds, but thousands actually came out to complain of one illness or the other. And the doctors were able to render this service very, very effectively. Honestly, we don't have anything to say, but thank them immensely, and also pray Almighty God to reward them in abundance. This organization has been established for the past 20 years, and with the sole objectives of helping the needy, especially in the health science sector. And those, we believe that, yes, there are so many people there that are sick, and then even to get some financial support to treat their illness has become a problem. And these are the volunteers who actually come out to render the service without any charge. So we thank them immensely, and they will pray Almighty God to continue to guide all the members and then increase their wisdom and strength and the wherewithal to provide this health service to humanity. Thank you very much, and then God bless you.
Thank you, sir. We honestly recognize your support and offer of guidance for what we do as our patron. And we recognize also you share our passion in aiming to provide healthcare in Nigeria as best as we can, because you are on record for showing your concern about the healthcare tourism that Nigerians end up going to other countries looking for qualitative healthcare. We essentially hope with time, with your support for voluntary organizations and good governance, we will be able to achieve a credible and internationally recognizable quality of healthcare service. Thank you, sir.
God bless you. Thank you.
Thank you.
Thank you. You're welcome. You're welcome.
Thank you, sir. Our next keynote speaker is Professor Lawal Umar. Professor Lawal Umar is a senior colleague to many people on this platform, a contemporary to colleagues on the platform as well. Professor Lawal Umar is a fellow of the West African College of Physicians as a pediatrician. He is also a honorary consultant pediatrician at Ahmadu Bello University Teaching Hospital, Zaria. He currently heads the Pediatric Infectious Disease Unit of the Pediatrics Department at Ahmadu Bello University Teaching Hospital. Professor Lawal Umar is a member of the National Task Teams on HIV and Prevention of Mother-to-Child Transmission of HIV since 2005. He has been part of the Neonatal Life Support Training Coordination Team, and which is a training program that was set up between AHDT and ABU Teaching Hospital. Professor Lawal Umar is also a board member of Nigeria's Top TB Partnership. He is chairman of ABU Teaching Hospital Epidemic Response Committee since 2006. Professor Lawal Umar also chairs the ABU COVID-19 response team, and currently he is the coordinator of the Institute of Child Health of the Ahmadu Bello University Teaching Hospital. Professor Lawal Umar, as was mentioned by the chairman, has been quite supportive of AHDT's program. So we will now listen to his keynote speech on the role of AHDT in healthcare development within Nigeria, perspective of local collaborating professionals. Professor Lawal Umar, you can go ahead.
Okay, thank you very much, LOC Chairman. Please, may I have your permission to share my slides?
Yes. Do you have the control for the slides now?
Yeah, I just want to find out now. Are you seeing my slides or not yet?
We can see them. They are showing on the. Can you see them?
Yeah. Yeah, I can see that.
So,
are you seeing my slides?
Yes.
Okay, so I can start.
Yes, please.
Okay. Thank you once more, Mr. Chairman. Invited guests, ladies and gentlemen, my name is Lawal Umar. A professor of pediatrics at ABU Teaching Hospital, Zaria. Let me plead for your indulgence to stand on existing protocols. I feel very much delighted to be invited to make this presentation on the role of AHDT in healthcare development in Nigeria, perspectives of local collaborating professionals. On this historic occasion of the 20th anniversary of the Africa Healthcare Development Trust. I intend to follow this outline, starting with a background, going through the areas of and scope of collaboration and the challenges and constraints that we came across along the line, and conclude with a summary of the accomplishments. The objectives of the Africa Healthcare Development Trust, as outlined here, helping to improve health of less privileged citizens in poorer parts of the country, as well as training of healthcare staff, both formal and informal, in the community and the hospital setting, providing training on infection prevention and control, and helping with health resource management. Other objectives include those of training medical and surgical conditions for both children and adults, and general screening for diseases such as hypertension and diabetes. The Ahmadu Bello University, as you may recall, was established way back in 1962, a first generation and pioneer university in northern Nigeria. Since then, the institution has facilitated the establishment and development of many other universities in the region. The medical faculty took off in 1967 and graduated the first class in 1972. But the faculty only became a college of medicine not too long ago in 2016, in spite of which it has produced several sets of graduates, including diaspora colleagues in the UK that nurtured the AHDT. The teaching hospital is situated to serve as the Ahmadu Bello University Teaching Hospital, and has been churning out several medical professionals and trained paramedics, providing manpower to many parts of the country. So what led to the birth of the collaboration? The AHDT and the ABU Teaching Hospital share common goals in the areas of capacity development and community service. And in this perspective, and after several consultations, it was agreed to work in collaboration to achieve these goals. And therefore, a memorandum of understanding was signed way back in 2005, really, not 2015, to facilitate the actualization of these goals. In the areas of capacity building for skills or newborn resuscitation, mentoring for laboratory staff for improved service delivery and support of services with provision and servicing of equipment, as well as provision of a community-based service through periodic healthcare improvement projects. We also had exchange visits as part of the collaboration. Next slide, please. Next slide. These are pictures from the inception of the collaboration of advocacy visits by members of the AHDT, and as well as staff of the Hospital of Stockport Foundation, led by Dr. Alison Jobling. The picture at the top here is showing the Chief Medical Director then of ABU Teaching Hospital, Professor Rafin Dadi. And the lower picture is showing the Vice Chancellor of Ahmadu Bello University, Zaria, with members of the AHDT and the staff from Stockport Hospital. Next slide. The areas of the collaboration and the scope. Next slide. They largely started with foundation trainings. Next slide. The first training was the inaugural training of trainers that took place in 2007, where a couple of staff from the pediatrics and obstetrics departments of ABU Teaching Hospital were trained and certified as pioneer master trainers by personnel of the UK Resuscitation Council and supported by the Stockport Foundation Trust. That foundation training also included other categories of staff in relevant departments where deliveries of newborn babies take place. Next slide. This slide here is showing a table summarizing the numbers of ABUTH staff that were trained on site at the foundation training. And this included 29 doctors and 35 nurses, making a total of 64 personnel trained. And this slide is showing a summary of the numbers of invited staff that were trained from various hospitals across northern Nigeria, totaling about 19 facilities, including 21 doctors and 34 nurse midwives, totaling 55. The health improvement projects form part and parcel of the collaboration and the activities, and they consist largely of activities simultaneously executed at the selected hospital facilities. They will include needs assessment visits conducted in preparation to seek consents, identify priorities, and prepare service points for the incoming project. And the activities are carried out by various teams of professionals, including physicians, pediatricians, gynecologists, and surgeons. Each team is given assigned targets expected to be achieved within 1 to 2 weeks period as planned in the proposal. The project coordinator, Dr. Abubakar Zubairu, and the team lead would supervise the activities of the various teams to address immediate challenges. And the team leads submit unit reports at the end of the activities to be compiled and presented as challenges and recommendations to administrators. The capacity building activities form part of the health improvement projects in all the facilities visited. And they include training workshops on newborn resuscitation for hospital staff across most of the northern states, and training workshops for community-based healthcare workers, including traditional birth attendants. The training activities were followed by monitoring and an audit process to assess the effectiveness of the training. We also partake in development of clinical management protocols, as well as algorithms and treatment guidelines for host facilities, and conduct joint teaching work rounds with host facility staff. Next slide. These slides are showing classroom and practical training sessions on newborn resuscitation for hospital staff, showing points demonstrating the use of respiratory support equipment to resuscitate newborn babies. Next slide. Next slide. The next slide is showing delivery scenarios, as well as scenarios where staff are taught skills of taking deliveries in a safe manner and passing umbilical catheter for babies that would require such during resuscitation. The lower picture on the left-hand side is of traditional birth attendants also being trained in the classroom. Next slide. This table on this slide is showing a summary of the healthcare workers trained in host facilities across the years and across the facilities that benefited from this training. As you can see, there were over 140 doctors, over 400 nurses and midwives, over 250 community health officers and extension workers, as well as over 450 traditional birth attendants that benefited the training, all totaling 1,264 over the years. Next slide. On this slide is a sample of the training certificate that is offered at the end of the training to staff of host facilities that benefited from the training, certifying that they have competency in newborn resuscitation and neonatal life support. Next slide. Yeah, these are pictures of the foundation training for traditional birth attendants at the Sabongari Health Center, led by the training coordinator. These are TBA kits, and the contents of which are given free at the end of the training to traditional birth attendants for safe practice in their communities. We made a journal article publication that was mentioned in the speech by the chairman on the evaluation of cognitive effect of newborn resuscitation for hospital staff. Next slide, please. The publication was in the Annals of African Medicine in 2018, and essentially the finding in the study showed that the lowest cadre of medical and nursing staff performed much better than their senior counterparts in the training. Next slide. Next slide. The service delivery are very important components in the health improvement projects, and usually they would be announced to sensitize the public for the upcoming events. They would include medical and surgical consultations for the public, offer of free medications, and general surgical and specialist procedures in operation theaters, as well as delivery and maternity care services. Referral links would also be established for cases that would require further management. This slide is showing the typical scenario of high client turnover that is witnessed on a daily basis during the 1 to 2 week period of the project. And the teams get to clear these clients by the end of the day. These are scenarios for medical consultations going on at different sites. Next slide. Yeah, next slide, please. These are general surgery teams operating at various sites, and these are ophthalmology teams examining and operating their patients. As you can see, the clients here are post-op patients that are waiting for recovery and discharge. Lots of vision has been recovered for many clients who have conditions as simple as cataract. This slide here is showing medicine donated by Africa Healthcare Development Trust that comes with the services provided. Lots of medicines that go around virtually all patients that present, and often with surpluses left and donated to the hosting facility. Next slide, please. This slide is showing a summary of the numbers of patients with various conditions managed in host facilities. In all, over 24,000 various medical and surgical conditions were treated over the years across these facilities. And talking about cost analysis, the financial expenditure for Cabo General Hospital, as an example, alone came to the tune of over 55 million naira at the time this project was conducted. Next slide. Advocacy is part and parcel of the activity, and is usually a preliminary event in preparation for health projects. And this would include advocacy to state governors, commissioners for health, directors of public health, traditional leaders, head of institutions that we have visited, amongst many others. Needs assessments would have been conducted, and agreements reached on the scope and priorities. And it was also an opportunity to provide professional advice to health administrators. And project reports and achievements generated at the end of the activity are presented with recommendations to improve on funding, clinical governance, service delivery, and the likes. These pictures are showing the AHDT officials at the Gombe Specialist Hospital when the then state governor of Gombe State and the First Lady made separate visits to observe and appreciate what the visiting team was doing at the State Specialist Hospital. Next slide. This slide is showing the visiting team with His Royal Highness, the Etsu Nupe Alhaji Yahya Abubakar. The first picture on top is a courtesy visit on arrival by the team. And the next on the right-hand side is His Royal Highness addressing members of the team when he visited the team at the Federal Medical Center, Bida. And this picture here lower down on the left is that of the AHDT officials receiving royal gifts at the end of the activity by His Royal Highness. Next slide. Yeah, this is showing the team when they visited His Royal Highness, the Emir of Kontagora, Alhaji Saidu Namaskar, at the end of the project activity at the General Hospital Kontagora way back in 2015. Next slide. And this is advocacy activity by the project coordinator, Dr. Abubakar Zubairu, who was paying a courtesy visit along with some AHDT officials to the then State Deputy Governor, Alhaji Musa Ibeto. And this is the former Deputy Governor visiting the team to appreciate what they were doing at the Federal Medical Center, Bida. Next slide. And this slide is showing His Royal Highness, the Emir of Gumel, Alhaji Mohammed Sani, presenting certificates of appreciation to visiting team members at the end of the activity in Gumel. Infrastructural support have been part and parcel of the activities. And for us at ABU Teaching Hospital Zaria, we have continued to enjoy provision of training facilities, including the mannequins, that is the dummies we use for resuscitating babies, and other accessories, as well as the guidelines and protocols. We also keep receiving respiratory support equipment, majorly for the neonatal unit, and then also repairs and maintenance of machines at the newborn unit, as well as in the laboratory in the radiology department. At the General Hospital Bida, AHDT has performed renovations at the maternity and neonatal units and provided benches in waiting areas, as well as installed solar panels and inverters to power the renovated units. At the General Hospital Gumel, there were also some infrastructural changes that included commissioning of a new delivery bed to replace the old one with provision of overhead water booster tank. Next slide. Yeah, these are some pictures showing the areas that were renovated at the General Hospital Bida, an extension made at the GOPD, the General Outpatient Department. And these are the interior of the labor unit and the neonatal unit that were refurbished and powered by solar systems. In terms of humanitarian support, we have enjoyed and continue to enjoy a lot of benefits from support of infrastructure at the Zaria Orphanage Secondary School with funds donated by the Wise Pharmaceutical Company in the UK through the AHDT. This include funds that facilitated the equipping of a library to its standard, a science laboratory, and provided funding that was used for registration for O-level final examinations for students at that institution. There was also this, there has also been this provision of indigent support funds for the needy in a dedicated account of Ahmadu Bello University Teaching Hospital, which provides funds in the region of 10 to 60,000 naira for medical care or surgical care, as the case may be, for eligible patients. And so far, over 500 indigents have benefited from inception of this support. There is also a particular support of a trip to India for a child to have surgical remedy for a complex congenital heart disease way back in 2015. Next slide. This slide is showing the renovated areas, the equipped library with books and furniture at the Zaria Orphanage School, the science laboratory, and a computer laboratory. This slide here is showing Abubakar Yusuf, now an adult, who presented to us at the age of 15 years during the Kontagora project in 2015. And his problem was that of an undiagnosed congenital heart disease for which he has been attending the Usman Odanfodio University Teaching Hospital, where he has been having symptomatic relief by way of phlebotomies or reduction in his blood volume at a frequency of once in 2 to 3 months to permit physical activity and manageable living. So he was presented to us and he had support of up to $10,000 that enabled his trip to India, where his condition was evaluated and he was found to have an inoperable congenital heart disease, but he's now living with antihypertensives to alleviate his pulmonary hypertension. This is the educational exchange visits have been also part of the collaboration, and the project coordinator has made several visits over the years and continues to do so to our facility and many others. And we've had working tours of our administrators, the CMD, HOD of pediatrics, Kempa, and the senior nurse to attend Stockport in 2010 and benefited a lot from mentoring activity. We also had hematology and public health staff visit ABU Teaching Hospital in 2008, and a lot of mentoring activity came along with that. The UK Wise Pharmaceuticals has also developed into a partnership with ABU and set up a farm, ABU Wise Pharmaceuticals, to be situated at the Barodiko Hostel. A few students have visited Zaria on elective postings, but this sort of visits and subsequent plans for other exchange visits were stalled by rising insecurity in Nigeria. Next slide. We have had numerous challenges and the chairman has mentioned some of these challenges. They also include a limited scope of services offered at the health improvement projects, especially determined by budgets available and time availability of personnel that participated in that in those activities. There was also a lack of mechanisms for long-term assessment of knowledge and skills retention of staff post-training. We also have information about frequent redeployment and transfer of host facility personnel who would have been trained to other areas where they can no longer practice the skills they learned. There is the problem of lingering insecurity, and most recently the COVID-19 pandemic that have limited activity of the project. We came across on a few instances lack of sincerity of purpose by administrative staff who were reluctant or completely denied permission for conduct of health improvement projects in some parts of their states. We've also had some agencies that requested proposals to conduct neonatal life support trainings, but they they obtained the budgets for this and dumped the training teams to conduct their own activities. So I want to conclude by observing that the AHDT-ABUTH collaboration has facilitated the AHDT's goals and the realization of institutional missions for manpower development for our facility and most of states in northern Nigeria, where formal healthcare workers and informal healthcare workers were benefited from trainings, including traditional birth attendants. And we have an opportunity to take healthcare service to thousands of citizens in their domains. We've also had this opportunity of having the Indigent Support Fund that was provided for the needy. It was also opportunity for provision and maintenance of infrastructure and basic medical equipment. We benefited immensely from professional guide on health governance to our hospital management and many state administrators. I thank you very much for listening to this presentation.
Thank you, Professor Lawal Omar. You have a wealth of knowledge and a wealth of resources to share with the participants. And you made my job as chairman of the session a bit difficult because I wanted to stop you, but I think every bit you presented is honestly quite relevant to the 20th anniversary meeting. So we sincerely thank you, and we hope we will continue to enjoy this collaborative interaction between you and us. And we also hope there will be more and more colleagues that will recognize our intent and the future journey that we hope to have for the next, hopefully another more years to come. Now that we are about halfway through the program, we thought we will have an opportunity to take a screenshot of this virtual meeting with all our dignitaries so that we are able to have this as a sort of formal record of attendance. So Aliu, if we can change the settings so that we can have the panel view so that all the panelists as well as His Royal Highness and His Excellency will be in the frame so that we can have a screenshot. Can we have the, okay. So we want the gallery view so that we can have a screenshot before we go on to the next sections. Okay, very good. So His Excellency, as well as His Royal Highness, will want to have your video, please, if it is possible. Aisha, representing the CEO of the diaspora. Very good. Okay. Thank you very much. We will take a screenshot as a reference. Okay. So I will now hand over to Dr. Ado Yusuf, who will chair the next half of the sessions of the meeting so that we can continue through the program. Dr. Ado Yusuf.
Thank you very much, Falalu. My name is Dr. Adu Yusuf. I hail from Gombe State, and currently I'm a consultant physician in Manchester, North Manchester General Hospital. All protocols observed. Our first topic in this interactive session is the response of the Nigerian government to the COVID-19 pandemic. There is no person better to deliver this talk more than the person who has headed the presidential task force. I have the honor and privilege to introduce Dr. Sani Aliyu, Fellow, Royal College of Physicians of the UK, Fellow, Royal College of Pathologists. He is a senior consultant in microbiology and infectious disease at Cambridge University Hospitals. Just a brief about him. There's a lot about this gentleman, but I'll just be very brief in that regard. His alma mater is ABU Zaria, which I'm very pleased to say. He was first appointed from Cambridge to head the NACA, which is the Nigerian Agency for Control of AIDS, a position which he held from 2016 to 2019. After that tenure, he came back to Cambridge to carry on his role as a senior consultant, but only to be called back to Nigeria to head the presidential task force on COVID-19, the federal government's response. So that's really a very highly placed position. Now a little bit, while he was the NACA DG, he is credited with having successfully delivered the largest HIV-specific survey in the whole world. That's a great achievement. I'm more than pleased and very privileged to welcome Dr. Sani Aliyu to give his talk. Over to you, Sani.
Thank you. First of all, can I start by congratulating Africa Health Development Trust. It's really impressive seeing the sort of work that you've been doing in Nigeria. For some of you that are already engaged, I don't think it's a surprise, but to me, it came as a really pleasant surprise knowing how much you have put in. So congratulations. Secondly, I would like to apologize because I will have to leave at the end of my presentation. I'm actually on call at the moment, but I'm very much grateful for the time given to me to present some of our work. Now, when I spoke to Dr. Falalu, he actually gave me 5 minutes. I thought it was 10 minutes. So I said to him, it's 10 minutes yesterday. And he said yes, but it's really challenging to present the work we've done in Nigeria over a 10-minute period, but I'll try as much as I can to keep to time. Okay, so first of all, a disclaimer, I'm no longer the national coordinator for the Presidential Task Force. So whatever I say here is really more of my personal view rather than the view of the PTF or the steering committee as it is now. So this is how I intend to present my slides. So how did it all start? So back in March, around the first week of March, I went to Nigeria just on a personal visit, and I happened to see the leadership, and we had tea, and I was asked about COVID-19, and it was a question that came out completely out of the blue, asking about the COVID-19 pandemic. Is it serious? I said, almost certainly, I think it's going to be a big thing. And the second question was, well, what should we do about it? And are we going to be able to handle it? And I knew from our experience from the Ebola outbreak that Nigeria does have a track record of dealing with pandemics pretty well. We also have a pretty good manpower in Nigeria. Unlike other African countries, for instance, when I was in NACA, whenever we put out an advert, there was no shortage of capable people applying. Which isn't the case for a lot of African countries when it comes to public health programs. And then, even though our health infrastructure is relatively weak, but within the private sector, there are actually areas of pretty good practice, and some of our teaching hospitals in the urban areas are relatively okay compared to other countries. So overall, I thought that we should be able to handle it, but nobody knew the extent to which COVID-19 will come and dominate our lives. So virtually on the same day, I was asked to sit down with one of the secretaries, and we drafted the PTF. With the Secretary to the Government of the Federation, Boss Mustafa, chairing, myself as the National Coordinator, 9 ministers, the Chief Executive of NCDC, the DG of DSS, and the WHO Country Director. And then subsequently, some months later, we brought in the Chief Executive of Primary Healthcare because of the importance of vaccine, which was just emerging. It's also important, I think, to say that we started off on a completely clean slate in terms of the secretariat. We set up a national COVID-19 response center, which had an incident management structure. But basically, I was the only person in the office to start off with. So it was quite a challenge at the beginning. So this was how I structured the secretariat. We operated what we call a pillar system, which is quite common within public health. So we have EPI, surveillance, a laboratory pillar, infection prevention control, which feed into NCDC. The case management and the research, as well as the point of entry pillars, fed into the Federal Ministry of Health. Then we had a risk communication, which was led by the Federal Ministry of Information and Culture. And then security, logistics, and mass care, which was chaired by the Honorable Minister for Humanitarian through NEMA, and also supported by the security agencies. So this is a picture of one of our meetings, the midterm report. Here we have the SGF in the middle, and members of the National Assembly supporting us, as well as the members of the committee, the task force, and people from my secretariat. And it's probably worth mentioning that the secretariat, the way we set up the secretariat, it was essentially a mixture of people of varying backgrounds, drawn from the private sector, the NGOs, the UN system, the US CDC, and also from government. When I started, what I did was I put out numerous calls to Gates Foundation, to our UN partners and the US CDC, as well as to parts of government, and asked them to send me the best person you have in procurement, send me the best person you have in terms of operations, send me the best person you have when it comes to finance. And that was how we set up the secretariat, and it worked. So this is one of the meetings we had. At the beginning, we were having virtually daily meetings every day, going deep into the night. About a month or two later, we started reducing the frequency of our meetings. At the beginning, each daily meeting was followed by a daily brief to the country. I remember 3-4 weeks down the line, we started running out of. I started running out of topics to talk about because it was all getting too much. It was really, really stressful, but I think it was worth it. Now, this is a picture of one of the meetings we had with Mr. President. We were meeting with him initially every week, and then fortnightly, and then subsequently monthly, and then it turned to end of term reports. I must say, when it comes to COVID-19, what we do know is that the language of the leadership is what determines how well the response is run and whether or not you have a problem in your country. And we can see that with Brazil, we can see that with the United States, we can see that with Mozambique and some of the countries that had real issues with the COVID pandemic. Because if you are very clear as a leader that this is an issue, the public will support you. And I must say, Mr. President gave us all the support we needed. All the submissions that we made to him in terms of proposals were approved. As far as I know, he didn't decline any of our submissions to him. And I must also give credit to the SGF. He was able to chair our meetings really well, despite the fact that we had a desperate groups of people, ministers from varying backgrounds, some of whom wanted us to bring in traditional medicines, etc., into the response, which we completely disagreed with. But I'm very grateful to the SGF for really supporting us from the scientific and technical side and going with our decisions and advice. So how did our response run? So first of all, the decision-making policy. Now, this was a pandemic, and there was a lot of confusion at the beginning, very limited data, even within the UK. Panic. Nobody really knew exactly how the virus was going to behave. We knew that the decisions we were going to take was going to have a significant impact on people's lives and livelihoods. We also knew that Nigeria was at risk. We have very good air links with parts of the world, which in the past would have been an advantage in terms of our economy. But when it comes to a pandemic, it's a problem. High population density in urban areas, high prevalence of infectious diseases, and really relatively weak health infrastructure. So what do you do if you have a problem like this and you're not really sure what to do, and there's a lot of confidence from the leadership that you'll be able to pull this through? So just like most sensible people, what I did anyway was I put out a phone call to my friends. You call a friend. And that was what we did. We set up a scientific advisory group. We called it the Tuesday Advisory Group. This was a stakeholder group drawn from academicians, health policy people, and people dealing with pandemics in the past, social scientists, people very good with epidemiological modeling. And they were drawn principally from the UK, Imperial UCL and Imperial College, from Harvard in the United States, and academics from Nigeria. And it was led by Professor Ibrahim Abubakar, who works with the University College London and is currently the dean. And we gave him the role of a chief scientific advisor to the PTF. And a lot of the decisions we took was really guided by what the Tuesday Advisory Group gave us. Essentially, the way we operated. So this was an example of the people drawn from the Tuesday evening group, and they were also supported by a huge network of people from our donor community, including the World Bank, the CDC, etc. And essentially, we gave them access to our data, whatever they needed. If they ask us for geospatial data, done. The next day, they will have it. And that was really one of the advantages of having a presidential task force. The reach was really extensive, and our ability to leverage on our partners was really great. And what we did was we gave them questions. So we will ask them, what is the impact of, let's say, closing down transport links between the states? How would it impact the response? And they will go back and they will do the literature review. They will also do mathematical modeling, and they will give us the various options. And I'll then present it to the PTF, and we will argue about it, and then we'll come out and take a decision. And if it's a major thing, we will check with Mr. President before we announce. And this, in a way, limited the influence of any single country, donor, or organization in terms of our decision-making process. It enabled us to take major decisions at a time when it was really needed. So the precision lockdowns, for instance, our strategies regarding treatment and isolation and travel. And the best example, I think, was travel. When we introduced restrictions, we said you have to test before leaving for Nigeria, and you have to test at day 7. And then suddenly there was this huge pushback. Why are you testing twice? We call it double testing, but it was all related to the science of the disease. And it followed from the advice we were given by the group, some of whom actually advised the UK from the side of COVID as part of SAGE. And subsequently, we've been proven to be right, because a lot of countries now adopt multiple testing at various points within the incubation period. The main drawback, I think, was that the group was really limited. Their advice was limited to what we asked them. We did not ask them to provide us with policy briefs on topics that we were not interested in, but we did not feel was important. So we defined what we felt we really need, and we asked them to provide us the answers. And then secondly, we did not have a lot of economic experts until much later on. So the socio-economic impact of some of the decisions would have been quite grave. So these were the sort of interventions that were done, looking at the various deadlines, the closures. We closed for about 5 weeks, and then we slowly started relaxing and then opened schools, NYSC, etc. And the graph at the bottom shows the mobility change in retail and recreation areas. This is a mobility graph showing whether people are moving around or not. And you can see there was a significant decline, up to a 60% reduction in mobility throughout the country during this period and subsequent recovery. I'm not going to spend too much time on this because most of you will be able to get this data, but this is the global situation as at this week. And thank you, DG and CDC, for providing me with these slides. It just shows that there are increasing cases of COVID-19, as we all know, in certain parts of the world, including Africa. Just yesterday, the UK Chief Medical Officer announced that hospitals in the UK should expect to have a third wave, and I think that's going to come. For Nigeria, so far, we've tested 2.2 million persons and with 167,000 cases. But there's a caveat here. For each positive case, it's very likely we're missing about 10. So the true number of COVID cases we've had in Nigeria is probably around 1.7 million. And I'm sure the deaths will be at least several-fold that in terms of what we have. We have only about 2,000 deaths, but I think it's almost certainly, we've certainly had more than 20,000 deaths overall. So this is the epi curve. Nigeria had two waves, just like the UK. The first wave was much smaller. The second wave had a huge peak, and subsequently things settled. Now, people argue with me whether or not we are actually picking up cases now. And what I always say is when the numbers start going up, it's very obvious. Our treatment centers fill up and healthcare workers start catching COVID. So I'm very comfortable that the number of cases in COVID at the moment in Nigeria is actually very small, regardless of our frequency of testing. In terms of the variants, we do have the UK variant in Nigeria. We also have our own Nigeria strain, the B1525. This is based on ongoing sequencing, but again, a caveat, we are not sequencing enough. So our sequencing capacity is very low. So far, the Indian strain is yet to be detected in Nigeria, but of course, it all depends on how well we are sequencing. What's the impact? So there are always positive things that always come out. As they say, there's always a silver lining in every cloud. In terms of coordination, I think this was one of our main strengths, really. We were able to set up an effective secretariat and very effective coordination across the board with MDAs and other organizations. I remember in March when I went back to Nigeria briefly to round up the PTF, there was a huge resistance from parts of government as well as the legislature because of how effective the PTF was. And people were very worried that by stepping down to a steering committee, the PTF was going to become less effective. But the fact was everybody was tired, everybody was fatigued, and we needed a different way of doing things. So partner and private sector our work with them was really good. We really used private sector resources. Most of the things we did, to be honest, the resources came through the private sector. We were given 22 billion naira by the federal government from a budget of 85 billion. As at the time I left around March ending, we still had about 14 billion left because most of the resources came from the private sector. I know I'm running out of time.
Sorry to interrupt you. Yes, please. I've got another 2 minutes, please, to round up. Is that okay?
So I think I'll just skip a few slides. Just to say this was the positive impact. You can see the number of treatment centers opened, 131. We deployed over 4,000 oxygen equipment. We opened ICU beds. But to me, what I was most proud of was the training, the infection prevention control training. We've trained over 20,000 healthcare workers as a result of COVID, and also mobilized a huge number of people. But we have faced numerous challenges. The treatment centers were definitely inadequate. Testing remains inadequate. The lockdown, 40% of people in the informal sector lost their jobs. There was an issue of poor ownership by states and a low risk perception by a large chunk of the population. I had 10 things that went well. I'll not go through it. I'll leave the slides with you. These are all things that I think went pretty well. But the key question really is, will Nigeria be third time lucky? We know that the parameters that India had some months ago still exist in Nigeria. The issue of compliance with NPI measures, the general cynicism about COVID, the low vaccine uptake, the low testing, the health infrastructure. But to me, really, it's all about making sure that we have vaccines available. And I'm very pleased that the federal government has approved for COVID vaccines to be bought directly. This is really what is needed. We should not be waiting for handouts. We should negotiate directly with manufacturers. We should also remove the bottlenecks that have to do with vaccine delivery and improve on our communication. NPIs alone will not sort out COVID in Nigeria. In terms of other things, the prevention side, yes, we need to continue enforcement of travel measures. We need to scale up. We need to improve our communication. We need to improve testing. And we also need to be aware that if a third wave comes, we have to be prepared. We should not be caught napping again. And then finally, this is just an advice for more for donors and partners. I heard what the chairman really said in terms of the limitations of people in the diaspora and organizations in the diaspora working in Nigeria. And the key thing really, I had 4 or 5 points that I wanted to make, which I think is important. First of all, when you go in, encourage country ownership of the health system. We see a lot of situations where the foreign donors go in and it's almost like they take over control. You cannot do that. You've got to make sure that there is country ownership and transfer of skills. You also have to identify your conflicts of interest early, avoid undue influence, and build trust and true relationship. Because as they say, to whom much is given, a lot more is expected. We've got to engage as stakeholders because everybody has a role to play, particularly our traditional rulers and community leaders, and communicate effectively, because the best of plans may not see the light of day simply because of communication issues. And then finally, something that I'm very keen on is the issue of knowledge transfer. It's good to improve infrastructure, etc., but what actually makes up a hospital are the people in it. So training, transferring knowledge, and making sure that we build on the governance, clinical governance side that some of us are very used to here in the UK. So I'd like to thank you for your attention, and just to acknowledge some of the colleagues that I've worked with in the PTF, and it's been a real pleasure. But thank you very much for the opportunity to present this. Over.
Thank you very much, Sani, for a very, very important presentation. I'm sorry, but I had to push for time because we're running a bit late. Now, very importantly, now that you're back to the UK, we'll be pleased to have you join AHDT so that you benefit from your knowledge and expertise in that field. Sadly, you're leaving because you have you're on call, because this is an area that would generate a lot of questions. I foresee lots of questions coming in terms of PPEs to medical personnel, what vaccine is best for Nigeria, why was the infection, or why did the infection appear to be mild in Nigeria? There are lots of questions I can see that I would have loved to ask you, but sadly you're on call and you have to leave. But please do keep in touch with AHDT, and now that you're back, please do join us. We'll really benefit from you. Thank you very much for coming.
Thank you for inviting me. Thank you so much. I'll try and see if I can log on later on once I clear a few issues. So.
Thank you.
Thank you.
Now, thank you very much. Now, moving on now to our next speaker. The topic is experience of a trustee in helping AHDT to deliver its objectives. Now, I'm very, very privileged and honored to invite Dr. Muhammad Adai Salisu. He has been a pioneer trustee to AHDT. He's currently a senior special assistant to the President on Developmental Policy Matters and a member and secretary to the President on Economic Matters. prior to moving over to take up that position, he's been an associate professor at Lancaster University. He's worked internationally in lots of different places in the World Bank, WTO, and lots of the like. He's also been chief economist and advisor to the Islamic Development Bank and lots of other places that he's worked in. We really are privileged to have him as a pioneer trustee. He will be giving us a talk, and I would say from the outset that it would give you about 10 minutes, Dr. Dyer. Thank you very much.
Thank you very much, Chairman. I would also like to stand on existing protocol. Initially, I prepared a speech, which was roughly 15 minutes, but I will just discard that speech and just speak off it to make sure that I confine within the time limit, particularly given that the wonderful presentation by Dr. Sani Aliu has taken quite some time, but nonetheless it's worth giving him that particular opportunity. It gives me great pleasure to participate in this event, marking the 20th anniversary of the Africa Healthcare Development Trust Fund. And as Dr. Ado Yusuf said, I had been with this particular charity since the beginning or inception of it. Because at that time, I could remember I live just 20 kilometers away from Dr. Falalu Damwata, who is in Preston, and I was in Lancaster. And at that time, I was also doing my own charity work, collecting books and taking them to Nigerian universities. But as you in the AHDT found that sending books or materials and consumables can be quite challenging. So I really admire your courage by moving and changing strategy towards making physical presence in Nigeria. So this is not a small feat. It is an excellent thing that you have been doing, particularly given that your work was demand-driven and you are doing it free of charge. So I pray that may God in his infinite mercy grant you the wisdom, wherewithal, and good health to continue to provide such services to our teeming population in Nigeria. So the achievement you have done is commendable, and we can see from what is already on your website that you have established a solid track record despite huge challenges and great risks. Now that you have already done the journey over the past 20 years, I think my advice to you is to try and now think, what can we now do over the next 20 years? And that is very much important. So I believe that it is time for you to think strategically on how to upscale the activities and modus operandi of the charity. And this will require reviewing what you have done in the past, what went well, what went wrong, and then try to develop a comprehensive plan of action for the future. And this action will be very important because if you don't plan, as the adage says, you are planning to fail. So planning to do what you will do in the next 20 years will be very much important, as doing the situational analysis will enable us to reposition AHDT on a sustainable growth and impactful operation path. And this will also allow us to look at how can we expand the scope of those activities that we started. And I saw the chairman mention earlier that the mission is now to expand towards the southern part of Nigeria, particularly in the southwest of Nigeria. This is commendable, but do not just do that without proper a strategy of doing that. And if you do a proper mapping, a proper approach to what we call stakeholder analysis, you'll be able now to develop new approaches of widening the membership, of adapting strategic communication framework that will enable you to deliver or to disseminate some of the activities that you have been doing, and then what new ways of doing things will you now decide to put in place. So particularly the presentation by Abu Bakr, the Lawal Umar, about training of trainers. I think this is very important. But it is time to try and upscale that so that when you upscale the training of trainers, you will be able now to develop critical number of people who can now anchor AHDT operations on the ground in Nigeria. And by that, you will be able now to perform some of the operations in Nigeria at arm's length, particularly by leveraging technology. You know, we have telemedical or telemedicine services that are now being used globally. So by training people who could really cooperate and collaborate with you in Nigeria will now reduce the number of people traveling from the UK or from around the world to go physically and handle these operations. But having said that, all this analysis or these activities that you will do will require considerable resources, organizational acumen, and guiding principles in the form of coming up with a strategy that is fit for purpose. So I therefore urge that going forward, we should develop a plan that will provide strategic direction and guidance to AHDT, thereby enabling it to make huge transformational impacts. There are a number of ways where we can draw a very sound strategy of placing AHDT on a very sound future. But I will not go into detail in doing that because this is my job when I was at the African Development Bank as well as the Islamic Development Bank. Our job is to try and see how we plan to reposition organizations or institutions using some specific tools and instruments. I will not go into dealing with those, discussing these tools and instruments, but as a trustee, my doors will always be open to try and help you develop such strategies that will see AHDT expand its membership and also develop financing mechanism beyond membership contribution. And there are a number of ways that we can do that to make it successful. So having said that, I will just want to state that institutions such as the Islamic Development Bank and the African Development Bank are now very receptive in providing financial assistance to charities such as yours. I remember when I was a senior economic advisor to the president of the Islamic Development Bank, my role was to try and identify charities such as AHDT in Africa with the help of assisting them to try and grow bigger and stronger, particularly in the field of health and education. And at that time, I think before I joined the presidency, the Office of the Chief of Staff in 2017, I was sitting on a $2 billion fund for that purpose alone. So bringing the attention or this particular information or knowledge to organizations such as yours will enable you to tap into such resources so that you will be able to expand the scope of your activity. And in fact, in my previous thinking, I was saying that I sincerely believe that as AHDT grows from strength to strength over time, it could easily metamorphose into a bigger concept or idea. And what do I mean by that? If you begin to tap into these resources that I just mentioned, then perhaps you would be able to even establish your own medical related ventures that could generate revenues to fund future operations of AHDT without seriously falling back on membership contribution. Because I know drawing resources from individual members can be very, very difficult and challenging. So, but if you have got a kind of a stable funding mechanism, that will really help you to do that easily. And I can provide services to you in order to link you to various organizations that you will be able to make it easier for you to expand the scope of this operation. So I would like to conclude that as a trustee of this charity, and also as an economist, a banker, a public servant, a policy practitioner, and a business management consultant, my doors will always be open to AHDT on how best to achieve some of the ideas I propose here. I wish you successful deliberations, and thank you very much.
Thank you very much, Dr. Muhammad Salis Adaya. We're very grateful for your speech, which is very inspiring. I know we can always count on you. You've helped us, and please leave the doors wide open because we'll be coming to see you and for further assistance. Thank you very much for your speech. I hope you will stay and answer some questions if there are any at the end. I'm very mindful of the fact that we have got very important dignitaries, so we'll move on to the next speaker. Now, the next in line is Honorable Dr. Abike Dadbiri Erewa. Now, we've got a recorded speech from the chairperson and CEO of the Nigerian Diaspora Commission. I know Aisha Dankano is around to represent her, but what we'll do is play a video which had earlier been sent to us by the Honorable Abike Dadbiri Erewa. Now, she is a very inspiring person. She's helped a lot in her position as a diasporan, as a CEO of the diaspora to get Nigerians back from different parts of the world back to Nigeria. She, while a member of the House of Rep, she sponsored lots of very important bills. Her interests really include those of the welfare of Nigerians in the diaspora, welfare of the underprivileged, the voiceless, the poor, and the disabled. I'm pleased to have her speech played while Aisha would listen, and if there are any questions at the end, we'll ask Aisha Dankano to respond. Thank you very much.
Hello everyone, my name is Abike Dadbiri Erewa, Chairman, Nigerians in Diaspora Commission. Wow, congratulations, congratulations. I join everyone in celebrating this milestone with you, African Healthcare Development Trust. From a small gathering of friends 20 years ago, an informal gathering 20 years ago, to this humongous achievements 20 years on. Really, we're proud of you and we celebrate you. I will say a hearty congratulations. I want to particularly thank you for the enormous impact that you have made in the healthcare sector in Nigeria. And I also want to say something about you. You don't sit there complaining, oh, there are challenges, oh, the Nigerian factor, this is bad, that is bad. You got out of your comfort zone and decided to do something. You got out of your comfort zone and decided to give back. You got out of your comfort zone and decided to make a difference in the lives of Nigerians. So I celebrate you and congratulate you. And I want to tell you that the Nigerians in Diaspora Commission will be ever so willing to be your partner in progress. The things you have done, particularly in the area of training, mental health, research and development, and several others, is worthy of emulation. I know personally the kind of challenges that you had to go through in putting all these things together. But we at Nigerians in Diaspora Commission look forward to working with you to mitigate or at least limit some of these challenges by being the bridge between you and home and the many, many, many more things you hope to achieve in your next 20 years of existence. Congratulations, we're proud of you, and we hope that many more Nigerians in the diaspora in particular will emulate what you have done and give back and not keep asking what is it in it for me? Oh, Nigeria this, Nigeria that, Nigeria criticism. If every one of us throw our little pebble into the river, we'll all create positive ripples. You have created fantastic ripples and others should do the same. So congratulations, happy 20th anniversary, and we're proud of you. Well done.
That was a speech from Honorable Abike Dadbiri Erewa. Thank you very much. As I said, if there are questions, Aisha Dankano may answer those. We'll proceed on now. Our next topic is a talk given by a very important person. She is one of our patrons. She is an educationist and a philanthropist. Her name is Mrs. Marian Sarjana. Her topic is healthcare delivery a perspective of a patron and an educationist. A little about this lady. She's currently, as I said, AHDT patron. She's also Associate Dean of the Faculty of Medicine in Gulu University in North Uganda. She's also been internationally and locally been the chairman and a member of the very important committees. For example, she's been a trustee of the Manchester Global Foundation, a charitable organization which develops national international partnership. She's also been a member and a staff of the NHS for more than 45 years. She's got a lot of experience behind her. She's an educationist, as I said. She does well and get the best out of people. And without much ado, I will hand over to Mrs. Marian Sajina. Over to you. Thank you very much.
Thank you. Thank you for your kind words and introduction. Your Royal Highness, Your Excellency, distinguished guests, friends and colleagues, it's an honour and a privilege to be patron of such a compassionate and inspirational charity. The work of the charity is transforming lives, investing in people, their education and their health. 20 years is an amazing achievement. And what started off as a group of friends and colleagues with an idea that became a vision, and with hard work and commitment became a reality. I was attracted to the work of AHDT through a personal connection with Ibrahim Hassan and his passion for sharing his expertise in healthcare with people in a less fortunate position than himself. This giving back attitude is something I too am passionate about. He invited me to one of their meetings where I met other people who were equally passionate and inspiring. God gave me a vision for the African continent, and the majority of my work to date has been in East Africa. Here in the UK, we take our healthcare system very much for granted. So many countries, there is no system that can offer the level of healthcare at the point of need, irrespective of a person's circumstances. We have cradle to grave care from the poorest to the wealthiest. Provision of healthcare education and quality clinical equipment is also an important factor to consider in the holistic care of patients and education of staff. From the onset, improving education by public health campaigns, training of healthcare staff, transfer of knowledge, and delivery of care have been a priority for the charity. I won't go into all the projects because you've heard from Ibrahim and others, and I'm sure you'll hear some more as the conference progresses. Partnership and collaboration are also important to us. We know and we fully appreciate how much further we can go together. And you've heard about some of the partnerships that we have developed and the projects that have been delivered in collaboration, and you'll hear of some that we plan to deliver in the future. When you look at our website, you will see our members and board members are not all healthcare professionals. We are a diverse group. However, at present, I'm one of only a few women among all these handsome men. Not for the first time, however, have I held a role where this is the case. My role at Gulu University as an Associate Dean in the Faculty of Medicine, I'm not a medic. I'm not a Ugandan. I'm not a man. And also in my role of Director of Partnerships at Manchester University's Academic Health Science, there were 3 directors, and again, I was the only woman and the non-medic. Being different has its advantages. We are keen to involve women in our work. So if you are listening, or if you have a connection to any of our members, you know, please think about coming and joining us. Charitable work, particularly in the international arena, is not without its challenges. From planning overseas trips to finances, from organising leave to booking flights and visas, etc., group dynamics, ethical dilemmas, cultural challenges, they're all part of day-to-day life when we're working in this field. However, we work together to limit the challenges and, when necessary, find innovative solutions. As we enter the next 20 years, I hope to see the work of AHDT expand across the continent of Africa and beyond. We have an opportunity to engage with universities, hospitals, healthcare facilities, staff in new and innovative ways. Online teaching, webinars, clinical training are all available for us to develop and then to deliver. And this can all run alongside our trips with colleagues in person in country. This is an exciting time. If you're not registered as a member or a follower, this is the time to engage. Your time, your financial support, and your expertise can be invaluable to the work of AHDT. You will not only be helping transform lives, but you will see your own life transformed as you give back in a meaningful and productive way. Enjoy the rest of the conference, and I'm looking forward to keeping in touch and having. Thank you very much.
Thank you very much, Marian. Thank you very much, as always. Very pleased that you've been able to give that very inspiring speech. I'll move on now. As been mentioned earlier, AHDT has a lot of collaboration with Stockport University and Ahmadu Bello University in Zaria. So it's not surprising that the chief executive of that hospital, or rather the chief executive of Stockport NHS Trust, has sent a recorded message, a message of goodwill, which I would now ask to be played. Thank you.
Hello, my name is Karen James and I'm the Chief Executive of Stockport Hospital Trust. I want to welcome you today, a warm welcome to your conference. I'm sorry I'm not going to be able to be with you today. Unfortunately, I'm taking a short break after what's been a very, very difficult year for all of us. We are here today to celebrate the work of the African Health and Development Trust. I know that we at Stockport Hospitals Trust, that we have developed a strong relationship with you over a number of years with the teaching hospital in Zaria, Nigeria, and have contributed to a number of areas of clinical services, research, teaching and workforce. I'm also aware that we have established a charity to support the purchase of much needed medical equipment, which is quite amazing. It's lovely to hear about what's been achieved to date, and I want to ensure that you know that I'm fully committed to continuing to develop our special relationships and to continue to progress the programmes that have been planned for the future. It's really good to hear about the great successes that have happened over a number of years, and I want to ensure that you know that I'm fully committed to continuing to develop our special relationships and continuing the future programmes that we have in progress to ensure that we continue to develop and address the health and well-being needs of the Nigerian communities. I do hope you enjoyed today's event, and I look forward to hearing much more about what is going to be happening in the future. So enjoy, and thank you very much.
Thank you very much. That was a goodwill message from Karen Jones, the Chief Executive of Stockport NHS Trust. Now, we'll move on now to get into the question and answer session. During this period, there are questions still coming in, but while we prepare for the answers and get the relevant persons to answer, I would please invite our project director to please highlight the salient features, what is required, what applies for the project to be undertaken. As mentioned earlier by the chairman and other speakers, he's been very invaluable member of this association. So I would now invite Bakar Zubair to give us clearly stating what are the features required to undertake a project in Nigeria. Over to Bakar. Hello?
Can you hear me?
Yes, go ahead, please.
Thank you very much, Ado. Your Royal Highness, Alhaji Dr. Abubakar Etunupe Bagadoji, we are grateful for your time, despite all your hefty commitments. And we're also grateful to the High Commissioner for gracing our occasion. Now, when a project request is made, generally it comes from an expression of interest from a host community or from a state. And as soon as we have such an expression of interest, within 6 to 8 weeks, we have a quick meeting amongst the executive to see if it is something that is feasible. And once we agree, we get back to the community or the state in writing that we accept the invitation, and then we start the ball rolling. Between that time to the time that the project is implemented, there's a lot of hard work behind the scene. Contact with people, the community, the health services. Most importantly is the Ministry of Health in the state, because we often use government facilities and we need permission to be able to use such facilities. Now that's the most arduous job, because you have a state, for example, that doesn't even know about AHDT. You have people in the ministry that have no idea what is happening. And you have people in the community, sometimes within the health sector, who are suspicious about what our agenda is. But over the years, we have been able to establish reasonable contact with people. So from the inception, expression of interest, responding to those interests, to the implementation usually will take us about 3 months. So any community that's interested, we need an expression of interest. Most of the projects that we undertook initially were based on people who come from local communities who know about us and have invited us. So if there are people who are interested, they can contact us through our website and we will respond. Now, there are a few things I know what Ado asked me to comment about is how the process, but there was a comment about Dr. Adaya, and can I just make a quick comment about capacity building in most of our projects? One of our aims, obviously, the chairman has already outlined, is training people, impacting knowledge. And dating back to 15 years ago, when the newborn resuscitation training was set up, and for those who are not medic, that is a process of helping babies who are unable to establish spontaneous breathing, helping them to breathe. When the training was established 15 years ago in Zaria by the Stockport team, the aim was to use Zaria as a hub, and then use the hub and spoke approach, realizing that Zaria is the oldest health institution in northern Nigeria, is the largest, and has a manpower capacity. So we trained the trainers dating back to 15 years ago. And the aim of transferring these skills is to use other hospitals as spoke. So we trained the trainers in Zaria, and these trainers are the ones conducting these trainings across the northern region. So as we go across the northern region, the aim is to identify potential trainers and then train them as trainers, so you widen the scope. And so what are we doing nationally? We have been in touch with the National Primary Healthcare Development Agency, NPACD in Abuja. And the aim is to widen this concept across the nation, because they hold the key to the midwifery scheme. For those who don't know, there is a midwifery scheme back in Nigeria. I'm sure that a lot of audiences back from home. Now, the aim is to train all the midwives under the National Primary Healthcare Development Agency, and then identify potential trainers so that then they can train people back in their communities. So we have that concept already in place. So Lawal Umar did touch about the number of people that have been trained. So those people that have been trained, a few potential trainers have been identified and will be trained as we go along as trainers to be able to extend the training back in their communities. Oh.
Okay. Right. Is that you, Abaka?
Yes, just to keep the time, mindful of time.
Yes, that's right. No, that's okay. That's very, very important. And thank you very much for that. Now, may I please call on Professor and Consultant in Microbiology, Professor Sajjad Mirza Marza, to please give a vote of, I'm sorry, to give a goodwill speech, just for a few seconds or a minute, please. He is not a Nigerian, but has been a very important member of this association and is a trustee. Professor, over to you, please. Is Sajjad Mirza there?
Yeah, hello. Good morning.
Please go ahead.
Dr. Yusuf, yeah, how are you?
I'm fine, thank you. Please go ahead. Good message, please. Yeah.
It's amazing to be listening to this by the amount of work which is.
I think we're problem with the audio.
Unmute here. So can you hear me now?
Yes, that's correct. That's okay now.
So I am just mentioning, that it's heartening to see, how much people have done over the years to really develop and contribute to Nigeria and to the people of Nigeria and to the healthcare and facilities development and trying to give back something. So because of the COVID problems, it was a bit difficult, but hopefully, inshallah, with God help, we should be able to go and continue to contribute. And
I think we're problem with the
would
audio.
Like to be part of this anniversary today.
Thank you very much. Thank you very much, Sajjad. I really appreciate that.
Thank you very much.
Thank you so much. Just a quick question, please, for Professor Lawal Umar, if you're still around to answer before I hand over to the next chap. If lower cadre healthcare staff, TBS, perform better on practical resuscitation skills during newborn resuscitation training, how will we address this to improve the skills gap in our secondary healthcare setting?
Hello.
Hello, Lawal Umar. Did you hear me?
Please. Yeah, I can hear you.
You got the question?
Yeah, I got that question.
Yes,
I think
if you can be very, very brief, please. We're running late. Thank you.
Okay. I think he didn't get the correct message. What was found was the analysis was done on the training for healthcare workers in the hospital setting. And actually what was found was based on what was seen there, not comparing the traditional the healthcare workers in the hospital. So it was a comparison between cadres of medical staff only in the hospital.
Right. Okay. I think that was a different. The data wasn't clearly explicit. Maybe that's why the chap asked this question. Thank you very much for that quick response. I will now hand over to the chair of the organizing committee. Falalu, over to you. Thank you very much. Thank you.
Thank you very much, Dr. Ado Yusuf, for your able, smooth run of the previous session. As you have had a lot of suggestions from our patrons and the speakers Obviously, the executive, with the support of the patrons, we will hope to chart our future plans of what the Africa Healthcare Development Trust will be doing, hoping to upscale our activities to be able to reach a larger proportion of the population in Nigeria and hopefully beyond Nigeria as well over the years to come. So as part of this 20th anniversary meeting, we will hope we will be able to reach out to participants who have registered through our website and have left their contact details so that we can get suggestions and evaluation of how well we have done so far. The truth is healthcare development and healthcare infrastructure, as well as healthcare delivery, is everybody's business. One of the reasons why NHS is working remarkably well is genuinely there is delivery of care at the point of need. It is disheartening in our community where sometimes you will see there is the need, but there is no resource to provide the service. It is usually more expensive for people to look after their health, whereas if there's a systemic setup where the service can be delivered, you will find that it is cheaper for both the society and the individual. A lot of us, one of the reasons why it became very important is because we have families in Nigeria. I'm sure there are lots of people who get contacts about supporting family members with healthcare bills, education bills, and things like that. So the better we are able to make the situation better in Nigeria, the easy for every one of us. So I hope the participant in this 20th anniversary meeting will be receptive in embracing our need to get suggestion and evaluation of the meeting so that we will be able to do better in the future. And genuinely, as Marian Sejana and our chairman also said, we need members and particularly women and non-medical staff. A lot of quality healthcare is not dependent on doctors only. We need supporting staff, we need administrative staff, we need people that will help us to be able to develop strategy. So doctors, we have the skill for treating one-to-one, but realistically, preventive healthcare, delivery of care is a systemic societal need, and we do need the support of everyone in society to be able to deliver such services. So we will have our debrief meeting and subsequently contact people. Those that have not been able to register, those that have joined the meeting through direct link, please go through the website and still register because we need your contact details to be able to maintain communication with you. Thank you very much. I will now hand over to our also co-chairman, who is one of the founding members of the AHDT, Mr. Jibril Ahmed Jibril, who is a consultant surgeon at United Lancashire NHS Trust. And I'm sure among the participants, there will be a lot of people that will recognize Mr. Jibril because he has been a pillar of the society, both here locally and back in Nigeria as well. Thank you.
Thank you, Falalu, for the introduction. It has been a long morning and I'm conscious of time, so I will not make it long. Obviously, AHDT has come a long way and has done quite a lot of useful activity, and we aim to continue. We wouldn't have been able to do this without the support of several people, and I would like to express AHDT's great appreciation and thanks for their support. In particular, we would like to thank His Excellency, Chief Sarafa Tunji Isola, who is now the Nigerian High Commissioner in London, and who is therefore, by virtue of that position, our father. We have had many good words and read many good words about His Excellency, but his being able to be with us today throughout the conference has shown to many people in practice what those good words were. We do hope that his post as the Nigerian High Commissioner will be a stepping stone for much more achievements going forward. Our patron, the Ethunupe, Alhaji Yahya Abubakar, has been a pillar of support and encouragement and inspiration. We wouldn't have been able to do as much as we have done in Nigeria without his patronage and his inspirational support. We wish him long life and good health and continued support for AHDT going forwards. We have the good fortune of having a very dedicated few people who were in the executive committee of AHDT. And despite their few numbers and the long journey that they have taken, they continue to exhibit a lot of enthusiasm and zeal, without which we would not have been able to accomplish very much. You have heard from most of the executive members already in their speeches, but we also need to mention Nurain Hassan, who is our financial chairman, who is actually based in Nigeria and who was responsible for putting AHDT on a sound financial footing to be able to undertake and execute a lot of these projects. None of this would have happened without the indefatigable and inspirational activity of our colleague, Dr. Wakar Zubairu, which has already been mentioned. Amongst us, we have all of our trustees of AHDT, an example of how dedicated they are to the organization. We have heard in person from Mohammed Salisu Adaya, who is one of the trustees, and we've also heard from Mrs. Marian Sajina. But amongst us, there is also Ibrahim Hassan Zaria, who lives here in Doncaster and hails from Zaria. We have Dr. Abdullahi Shehu, MBE, who has been a pillar to the organization. We also have heard a message from Professor Ibrahim Adamia Kasei, who is well known in Nigeria and also one of our trustees. Professor Sajad Mirza has spoken to us already. These are our trustees, and they are responsible for the legal and other statutory activities of AHDT, and we wish to thank them all for their effort. The organizing committee has spent many weeks and many days of very long meetings to be able to put this technical and online meeting, which is quite a hectic activity. It's not very easy. I would like to mention two of the members of the organizing committee for their role that they played and the strings that they have been pulling to even make today a possibility. And I would like to call on Mr. Abdullahi Sharif and also Dr. Aliyu Khalifa. They have been very active behind the scenes to allow this program to happen, and we thank them very much. And so with these few words, I would like to call on all of the delegates to think very much about how they can support AHDT to maintain and sustain its activities. A lot of the current EXCO members are coming to retirement, and the organization will need new blood to maintain sustainability and to take us to the next level. Thank you very much.
Thank you very much, Dr. Jibril. And we are genuinely quite pleased for this able and successful delivery of the 20th anniversary. And as we said, we look forward to getting feedback from participants when you get our emails. And I also want to take up this opportunity to really particularly thank His Excellency, the High Commissioner, as well as His Royal Highness, Esunife, as well as their team who work behind the scene to make His Excellency and His Royal Highness able to attend this meeting. As some of you may not know, we actually had backup of video recordings to have in case the electronic system fail in view of Wi-Fi broadband issues. So all the effort that has gone into producing this material is really a credit to the dedication of everyone involved. And we truly thank you very much. And I wish you a happy rest of the weekend. And to our committee, obviously, is back to work as usual. So thank you very much. And this marks the end of the AHDT 20th anniversary. Thank you very much.
Thank you very much. Goodbye.